Everyone. My name is Shrechna. I'm a PhD candidate at the Department of Political Science, and I'm going to moderate today's session. In the interest of time, I know you guys are logging in. We're going to get started as people continue to log in and join in the conversation. So on that note, I want to welcome you all to the Rockefeller College Lunch and Learn series. This is the final Lunch and Learn of the semester. We hope you've enjoyed the series so far this semester. For today's session, we're pleased to have Dr. Ashley Fox and Jillian Kirby Bronner join us. Let me give a brief round of introductions of our speakers. Jillian Kirby Bronner is a special advisor to the budget director with nearly 2 decades of experience in healthcare finance. Jillian has been working on a series of pieces through the Rockefeller Institute of Government on healthcare changes related to the One Big Beautiful Big Act, or HR1 as it is now being called, which some of you may have read. Her extensive and thorough research and analysis is helping to explain some of the major changes taking place in healthcare, who it impacts, what to be aware of, and the timing of the changes. Professor Ashley Fox is an associate professor in the Department of Public Administration and Policy at the University at Albany. She earned her BA and MA in political science from the University of Connecticut and a PhD in socio-medical sciences from Columbia University. Professor Fox was a postdoctoral fellow in the Department of Global Health and Population at Harvard between 2009 and 2010, and at Yale University in the Division of Health Policy and Administration between 2010 and 2011. Professor Fox's research focuses on health politics and policy in both the US and globally. Her recent research has focused on vaccine hesitancy and health misinformation. Today's topic is healthcare cuts are coming, what it means for the state budget, the healthcare system, and you. We're going to discuss how the federal cuts and changes to the Medicaid program are poised to substantially impact New York State's healthcare system and its overall budget. In this panel, Jillian and Ashley will discuss how the One Big Beautiful Bill Act and related rule changes could impact New York's healthcare landscape as well as potential responses to the cuts. Before I turn it over to our speakers, I'm going to go over the ground rules quickly. You're all requested to remain muted and hold your questions until the discussion is over. We are going to have time for Q&A towards the end of the discussion. You can use the raise your hand function on Zoom, or you can send your question in the chat. If you would like to remain anonymous and ask your question, you can send it to me in a private message, and I'm going to read it for you. If you submitted a question in advance, I will read it out for you. And with that, I'm going to invite Professor Fox to speak first.
It's not letting me unmute. Okay, sorry, it wasn't letting me unmute, but you would think by now I would have figured out how to get this to work. Okay, well, good afternoon, everyone. Thank you so much for joining us today for this extremely important topic, and I'm so thrilled to be joined by Jillian Kirby Bronner. So, as you all probably recall, just a little over a week ago, we were in the midst of one of the longest government shutdowns on record over the expiration of health insurance subsidies under the Affordable Care Act. Well, the shutdown is now over and the government is open again. But what we're here to talk about today is what happened, right? Why was the government shut down over healthcare subsidies? And more broadly, what are these looming 880 billion estimated cuts to Medicaid that are coming, and what impact are they likely to have on state budgets, particularly New York State's budget? Are some of the kind of doomsday scenarios that some of us might have heard about huge across the board cuts and millions of people losing Medicaid likely to come to pass? Or will the state find ways to fill in budget gaps? How extensive are these budget cuts really going to be? So to give us a better sense of the magnitude of these cuts and how they are likely to affect New York State's budget and New Yorkers, and our ability to make good on our healthcare commitments to different groups, I'm thrilled to be joined by Jillian Kirby Bronner, as Srijana mentioned. She's a special advisor to the budget director with nearly 2 decades of experience in healthcare finance, and she's written this series of publications on the Rockefeller Institute website that are just so informative. I can't even begin to convey how much information is contained there. I'm going to drop a link to some of those as we talk. But I wanted to start with a kind of broad question for Jillian about if you can just sort of give us an overview of the One Big Beautiful Bill and its primary goals, particularly as it concerns healthcare.
Sure. And thank you, Ashley. Thank you to the team at Rockefeller College for inviting me to join this important conversation. I'm really thrilled to be here. The One Big Beautiful Bill Act, or HR 1, was signed into law on July 4th, 2025. It's an omnibus piece of legislation that contains significant tax cuts with substantial changes to federal spending, particularly in healthcare. Its primary goals from a healthcare perspective are to contain costs, enhance program integrity, and shift more flexibility to states, ultimately aiming to reduce federal expenditures to offset tax cuts elsewhere in the bill. The reforms involve major changes to Medicaid, Medicare, and the Affordable Care Act premium tax credits. The legislation was passed through a reconciliation process, which allowed Congress to avoid a filibuster and obtain approval with a simple majority. And one thing I'll just add here is that, we're likely to see another reconciliation bill come through with additional changes, and we'll get into some of that later. But, it seems we're talking about part one of a multi-pronged reform effort.
Great. Yeah, thank you for that overview. Can you potentially walk us through what you see as some of the most significant changes introduced by the One Big Beautiful Bill to healthcare and to the healthcare system?
Yeah, great question. There are three lenses through which you can observe the changes that are included in the bill. The first being eliminating funding and eligibility for non-citizens. This includes Medicaid, Medicare, and marketplace coverage. These types of actions limit who the federal government allows to participate in these types of coverage options available through the programs. Medicaid is a means-tested program. Medicare is for seniors, and the marketplace is for those who are neither enrolled in Medicaid or Medicare, or who are receiving coverage through their employer. From a dollars perspective, the most significant reduction to federal funding in the bill was to eliminate eligibility for certain permanently residing non-citizens for advanced premium tax credits. To the extent that the state is obligated to cover a portion of these non-citizen persons, then the federal government simply shifted federal costs to the state rather than eliminating healthcare spending. The second lens through which you can look at the bill is through tightening eligibility for everyone in public programs. This includes instituting community engagement or work requirements and stricter eligibility checks for Medicaid. One of the examples is semi-annual verifications for certain populations. These types of actions create barriers for coverage, particularly creating unreimbursed healthcare expenses down the road. But in terms of state financing, to the extent that someone is not enrolled in the program, the immediate cost is eliminated from both the state and federal government. And the third type of lens that you can look at this bill through is eliminating perceived fraud, waste, and abuse. By tightening federal Medicaid funding for states through the elimination of various financing mechanisms, the federal government has limited the state's ability to maximize federal funding. In general, these actions take away opportunities to leverage federal funding, but do not materially alter the existing program design, meaning the state would need to make decisions to modify its existing Medicaid program or other state-funded programs outside of the Medicaid budget to make up for the loss in federal funding. Examples of this relate to provider taxation and state-directed payments, which the state uses to leverage federal funding for New York and its providers.
Great. So yeah, just to kind of pick up on, well, all of that really, but the last bit in particular, there are some people who might be thinking, well, it's unfortunate that some people might be losing their health care. I mean, obviously there's some new restrictions on what types of immigrants can get health care, and, some more hurdles that people need to jump through to get and stay on Medicaid. But people may be thinking, well, that doesn't really affect me. After all, I get my insurance through an employer. I'm wondering if you could walk us through a bit how the kind of broader repercussions of this bill overall in terms of the financial stability of the healthcare system, and how there might be some knock-on effects from the bill across the healthcare system.
Right. Healthcare is interconnected regardless of who your insurer is. And New York's healthcare economy is at least a $300 billion enterprise, serving not only the nearly 20 million New Yorkers that live here, but also functioning as a world-class healthcare system for patients around the globe. The provisions in the bill may create more uninsured and lead to more emergency room visits for primary care needs, as uninsured individuals tend to defer care until it becomes an emergency. As a result, this could increase uncompensated care for hospitals and providers, potentially straining their financial sustainability, especially for safety net providers. Now, to put this into context, 75 of the 261, or 29% of New York's hospitals, are currently financially distressed. Distressed hospital spending has increased by over 600% since fiscal year 2017 to over $3 billion annually today. So I'm going to drive this point home a little bit further. Several of the federal funding reductions take aim at how the state finances support for healthcare providers, in particular safety net providers. A portion of the $3 billion that I just mentioned in distressed hospital funding is paid through a directed payment template, which allows the state to leverage a federal share on approximately $2 billion in distressed hospital payments. These payments keep hospitals open that otherwise would close. Limiting the maximum payments under this program, as required by the bill, could take $500 to $600 million in federal funding associated with this program away from the state as the new requirements are phased in. Another way to think about this is that as the federal funding is reduced, the state has less to work with to deal with provider and resident needs. At some point, it becomes a zero-sum game, and a balancing is needed on the other side of the ledger, because no state has the ability to backfill the magnitude of reductions into perpetuity. That being said, the state is working very carefully with the provider community to mitigate losses and smooth impacts for consumers and providers. Those conversations are ongoing, and through the budget process and in the years to come as all of these impacts phase in.
Great. Yeah, thank you for that background. And yeah, I think it is important to stress that these, providers get payment when people have coverage, right? Providers get paid. And when they don't have coverage, that reduces the amount of money going into the system, which can cause instability across the system. But I want to go a little deeper into the impact of some of these changes on our various public health insurance programs, right? Because there's a few different programs that are affected in different ways. So I think the biggest one that people have heard maybe the most about, or at least that are poised to have the potentially largest impacts, are the ways that the One Big Beautiful Bill affects Medicaid, right? So can you lay out in a little bit more detail how these cuts are projected to impact the Medicaid program and its beneficiaries?
Yes. So as we've been talking about, there's some pretty substantial patient-facing or recipient-facing cuts, as well as financing cuts. On the recipient-facing end, there's the definition of qualified immigrant for the purposes of Medicaid eligibility. There will be new work requirements or community engagement standards for able-bodied adults ages 19 to 64. including parents of children over the age of 13. There will also be increased cost sharing requirements up to $35 per service and more frequent eligibility determinations for certain populations, sometimes as frequently as twice per year, as well as stricter verification processes. And then in addition to the recipient facing impacts, there are also fairly substantial state financing limits imposed by the bill. So more specifically, as previously mentioned, states will face limits on directed payment arrangements that support safety net providers, and also provider taxation is significantly limited, which is used as a fairly routine Medicaid financing arrangement.
Great. So yeah, there's a variety of different ways it sounds like that Medicaid is affected by these changes. But I think also people may be less aware that there are also some cuts to Medicare, right? And again, a lot of people get their coverage through Medicare, so they might be interested in how that could be affected by some of the changes outlined in the One Big Beautiful Bill. So could you tell us a little bit more about how Medicare might be affected by these cuts?
Yes, sure. And you're right. The bill includes some cuts to Medicare, but arguably less than was included for Medicaid. And they're much more nuanced rather than broad sweeping. In Medicare, the beneficiaries might experience a delay in, some of the Biden era expansions related to the Medicare Savings Program, which helps low-income seniors with premiums and out-of-pocket costs. And there are new restrictions on who can newly enroll in Medicaid with regard to immigration status, limiting coverage to U.S. citizens, lawful permanent residents, Cuban or Haitian entrants, and migrants of the Compact of Free Association. But it's not the same depth and breadth as we see in Medicaid. With regard to pharmacy coverage, there's also one additional provision where orphan drugs are excluded from Medicare drug reimbursement negotiation, drug price negotiations, and that might make things more expensive for people that have rare conditions, which is what orphan drugs treat.
Got it. Yeah. And you sort of in your answer started talking a bit about some of the changes affecting different immigrant groups. But New York State has long made commitments to cover different categories of immigrants, often with state-only funds, well beyond what other states do. So I'm wondering if you can just speak a little bit more to how this bill is going to affect New York State's ability to continue to do that, if you have a sense of that, or how it might change, in certain ways, the types of groups that are allowed to be covered, or just any comments you want to make about that.
Sure. And again, you're right. New York is one of around 14 states to cover undocumented children and one of 7 states to cover undocumented adults in the United States. This is not changed by the bill, although there initially was a provision that would have penalized New York through a reduction to the federal share that the federal government contributes to financing our Medicaid program. In prior bill iterations, that was dropped from the final version. However, the bill does significantly restrict access to Medicaid, Medicare, and enhanced and base ACA, premium tax credits for many lawfully present non-citizens. So specifically, it limits new enrollment in Medicaid and Medicare to only U.S. citizens, lawfully present residents, and Cuban and Haitian entrants, for example. For ACA subsidies for purchasing coverage on the marketplace, it also eliminates eligibility for many lawfully present immigrants who were previously able to receive them. And when I say who's not covered, this means like someone who's maybe in temporary protected status, or a refugee, or an asylum seeker, or someone who has parole. basically people who were living in the United States with the knowledge and acquiescence of the federal government, but maybe it wasn't a permanent path to citizenship. These changes open up a lot of questions for the state related to its obligations to cover those who are newly ineligible for subsidies, because there was a 2001 appellate court decision, Alyssa v. Novello, that stated that New York was obligated to cover certain permanently residing persons who are living under the color of law with the knowledge and acquiescence of the government. So this issue that you're raising is likely one of the biggest health-related budget questions the state will face this year, how it will finance those who it needs to cover and who it does need to cover. And it's a complex question with more to come from the Rockefeller Institute of Government in the very near future.
Great. Yeah, thanks for clarifying that. So it sounds like, just so I make sure I understand, that the federal government is changing. So the federal government has never covered undocumented people, right? But it is changing some of the lawfully present people that it might cover. And therefore, New York State needs to kind of figure out, like, are they going to pick up the coverage for those folks, and how what's the budget impact? Is that more or less?
Correct.
Yeah.
Correct.
Got it. Okay, I wanted to also pick up a little bit on you mentioned some of the kind of financially distressed hospitals in the state and the concerns around how these cuts could impact their bottom lines and ability to continue to operate. I did want to note that there are some provisions in the bill to address rural hospitals. So the Rural Hospital Health Transformation Program, established under the One Big Beautiful Bill, is meant to mitigate some of the negative impacts of this reduced insurance payments to hospitals. But what are your feelings about how sufficient that provision is going to be in terms of the mitigation of the impacts on rural healthcare?
So the Rural Transformation Program is a $50 billion 5-year fund intended to support rural healthcare. States were required to submit plans in November to, outline how they would use the funds to improve access to care, outcomes, and integrate new technologies in rural areas. It's definitely a positive step, and as far as mitigating the impact to the broader healthcare cuts in the bill, that's sort of an open question. New York has 20 critical access hospitals, 1 rural emergency hospital, 55 health clinics, and 119 federally qualified health centers. And New York represents 10% of Medicaid expenditures nationally. So we could potentially be eligible for up to $5 billion in total funding, and a portion of the fund is allocated proportionally. And best case, we can combine that with some of our safety net transformation program funds to mitigate impacts to providers. But every single state in the nation applied, and so we'll know early December what New York's allocation is, and there's only one bite at the apple. So I guess we have to wait to see just how much New York will get, and hopefully it's awarded something to help.
Great. Yeah, thanks for clarifying that. So it sounds like there is still going to be some gaps even with that that infusion into rural hospitals. I wanted to go back to, when I launched this discussion, I was mentioning the government shutdown over these expiring subsidies, right? So this is another way that the One Big Beautiful Bill affects funding to healthcare, but not through Medicaid specifically, right? More through the subsidies. So I'm wondering if you could just go into a little bit more depth about the subsidized plans and how they're affected by the changes that are outlined in the One Big Beautiful Bill.
Another great question. And I'm going to answer this in 3 parts, but I think also let's keep in mind that New York State Medicaid is over 7 million people. Medicare is, over 3 million people. And then we have our marketplace in New York, which is roughly 250,000 people. And that, you know, that was the driver of the shutdown nationally. There are three things that I think are kind of at play in this issue. One is the bill changes. The bill changes significantly modify the Affordable Care Act and the way the subsidies work by limiting eligibility for premium tax credits, eliminating automatic re-enrollment for those receiving subsidies requiring an annual re-verification, removing the cap on repayment of excess tax credits, and shortening that annual open enrollment period. And that's just a very high level, summary of the changes. There are many, many changes to the way enrollment works and the subsidies. But collectively, these changes make marketplace coverage less affordable and more difficult to obtain and maintain. That being said, this is a really complex area, and there's quite a bit of litigation and federal rulemaking in this space. We mentioned some of the articles that I've worked on through the Rockefeller Institute of Government. Two articles that I worked on relate directly to the bill changes and rulemaking in this area. And there's a lot of detail in there for those who are interested in the nuances of this. The second issue related to your question is premium impacts. In part, premium impacts are happening because the enhanced subsidy that was authorized during COVID, which is in addition to the base subsidy people were given as a part of the Affordable Care Act, was not extended as part of HR 1 or the One Big Beautiful Bill Act. Those were already going to expire, and the bill was silent on them. Premium increases are also happening because of healthcare cost increases. Hospital and pharmaceutical cost growth is one of the main drivers, or two of the main drivers of healthcare cost growth. And then third, within this premium impacts bucket, is when you take people out of a risk pool, right? So the bill changes who's able to enroll and makes it more difficult to enroll. When you remove younger, healthier individuals from a marketplace through stricter eligibility and verification requirements, then your risk pool becomes older and sicker, further driving up premiums. So you have sort of three issues within the premium impacts that are driving the debate. And then third, and which is a subset of two premium impacts, but sort of stands on its own, is the enhanced subsidies. So the recent shutdown in Washington made the enhanced subsidies a focus, but it was not part of the ultimate deal to end the shutdown, and further debate is ongoing. It's I would say it's very likely we see a renegotiation on the base and enhanced subsidy for purchasing coverage on the exchange through another reconciliation bill with additional healthcare changes. There's, in fact, rumors that we would see this legislation as early as today, or what it is. There's been already this morning articles coming out of Washington suggesting maybe there's a 1 or 2 year extension, but I think ultimately any of those deals will also include a discussion of whether there are health savings accounts and direct payments to individuals to use to cover healthcare expenses rather than through subsidies to insurers. And at the end of the day, this whole debate is going to be over the cost of coverage and how best to finance access to care, whether subsidizing insurers or giving subsidies to individuals is the most effective way to do that.
Wow, yeah, thank you for that. That's so many important points there, including that the subsidies are not really even the biggest, share of people that are impacted, right, by some of these changes, but it's what the shutdown fixated on, and also that the expiring enhanced subsidies are not even, not the only thing at play here, right? There's a lot of other things going on, and that there were pre-existing trends in terms of, the cost increase in these plans that could affect, how much people are paying. Plus, I hadn't even thought about the risk pools changing. So that's like really critical to think about. So as people start seeing the price tag going up, they may, choose to opt out of getting coverage, which then can, create this sort of, death spiral.
Adverse selection, death
Yeah,
spiral.
adverse selection. Yeah, exactly. Yeah. So those are great points. Okay, so I wanted to just sort of shift to some concluding policy insights here, and then we can, start opening up for questions. But I was wondering if you could walk us through a bit some of the timelines for these different changes, because, I think some are happening right away, some are happening after the midterms, a little bit, later on. Can you give us a sense of when people need to be prepared for some of these different changes?
Certainly. Many of the changes phase in over the next few months to a year or even later. For right now, individuals on this call or your family members should review their coverage, understand the potential changes to their eligibility or costs, and proactively seek information, whether it's through your state Medicaid agency, the marketplace, explore employer-sponsored coverage or other options, and make sure you respond to any communication from your insurer or the state to ensure that you are re-enrolled in coverage if you want it. New York has a 95% insured rate, and it's very proud of that statistic. And New York will be doing what it can to help residents remain covered, but you should make sure you're paying attention to that snail mail and electronic mail from anyone who's involved in how you are covered.
And I know we didn't, this isn't one of the questions I was planning to ask you, but I just was curious about the Navigator program and what you might know about what's happening with that, because the healthcare navigators can also help people figure out the healthcare landscape, right?
Yeah, I mean, I would say the bill did reduce some funding to states for navigators, but navigators are definitely a great resource to reach out to if you're not sure how best to be covered. You also can go on New York State of Health, which is New York's state-based health insurance marketplace, and go through the process of filling out your information. You don't have to pick which program you're enrolling in. You can simply go through the process, and based on your information, you'll be directed to the most appropriate program for you. And from there, get in touch with specific navigators or facilitated enrollers that can help you with the program that best meets your criteria.
Great. Yeah, thanks for that. So I guess just sort of final question to cap this discussion off, and then we can open up to audience questions. I was just wondering if you could put in perspective for us some of these changes outlined in the One Big Beautiful Bill and like sort of the magnitude of them. How substantial are they in kind of the arc of the history of healthcare reforms?
Sure, great question. Yeah, these are substantial changes. Major healthcare reform seems to happen every decade or so, and we are at the intersection of 15 years since the ACA was passed, along with major technological advances, which are highlighting the rapid transformation in the way healthcare is delivered. There was once a time where everyone went to a hospital in their neighborhood, regardless of the ailment, and now people go to specialists for specific diseases and maybe not even in their own state. Healthcare technology has already transformed the way that healthcare is delivered. And I would say more changes are still to come. I can't underscore enough that we're in this major transformational phase, not unlike the Affordable Care Act, which will shift the trajectory of healthcare for the next decade or so. And as I mentioned, it would not be unexpected to see even more changes, coming out of Washington over the next few months or even days. But just to conclude with a few thoughts, because I think these major reforms also bring opportunities to further shape impacts. Some of the largest costs have been avoided, and the state is working to minimize the impacts through, relationships with its partners and through the rulemaking process. And even though the cuts weren't as bad as they could have been, there is still this potential for coverage losses and budget impacts. The biggest cuts are likely to occur through coverage for non-citizens and limits on provider payment and taxation in terms of fiscal impact to the state. But as I said, the state's working with its partners to achieve the best possible outcome for all New Yorkers. And the other, important thing to keep in mind here is that healthcare is such an outsized aspect of both the federal and state budget and policy discussion that one thing for anyone who's on this call that's, maybe in an undergraduate or graduate program is that this is a fabulous time.
It was evil.
This is just a fabulous time to start focusing on healthcare if you haven't already. And there's so much here to start to unwind that it's a great time to get involved if you're at the beginning of your career or looking to, make a career shift. But I might be biased in that, but I think, if I could make a pitch to get more people to be involved in healthcare, I think, I have to take that opportunity. And just to conclude, Ashley and Renee and team at Rockefeller, this has been, a fabulous discussion, and I look forward to questions, and thank you everyone for taking the time to talk about and hear about this important topic. Great.
Yeah, thank you so much. And yes, definitely anyone out there who wants to get more engaged with healthcare, you can do it. And I'm teaching a class over the summer actually on healthcare policy if anyone wants to take that.
Thank you, Jillian and Ashley. It's time to open up for Q&A. I am going to remind you to use, the raise your hand option to say your question, or you can type it in the chat. So let's start with the question that we have from Joel Harmon. He's asking two questions, so I'm going to ask them together. What about the impacts on New York urban hospitals? And which do you think actually is the most effective way, existing types of subsidies or health accounts?
Sure. So I think if I recall, the question about impacts to urban hospitals came in while we were talking about the Rural Healthcare Transformation Fund. As far as urban hospitals go, well, it's not, you can't use this as a rule. I would say in general, more of the distressed hospitals that we talked about earlier in the conversation are urban than rural, although you can't use it as a rule. And so when we talked about safety net hospitals or financially distressed hospitals being affected by impacts from the bill, whether directly or indirectly through reductions to our ability to leverage a federal share through the directed payment template or through the potential to create uncompensated care visits, that would be probably the most direct impact to urban hospitals. And as far as what is the most effective way, existing types of subsidies or health accounts, we haven't seen a lot of detail yet on the health accounts. Healthcare is expensive, and there's certainly something to be said about a conversation about the most effective way or the most efficient way to finance healthcare. We have sort of a patchwork system in the United States where we have, employer coverage and a lot of publicly sponsored coverage. Some people want to see all coverage be financed like a Medicare for all, for example. Well, some people want to see it be a more market-based program. So my guess is that we'll see something in the middle, just because it requires compromise, and the existing system that we have is difficult to unwind. But I look forward to, watching that debate play out in Washington.
Thank you. We got a couple of questions in advance. So the next question is, does New York State still get more than it is entitled to in Medicaid, like it used to get in the 1990s?
So I guess the way that I would answer that question is New York is very good at using Medicaid as a verb, and maximizing to the greatest extent possible federal financing tools available to it to support its program and providers and recipients. In New York, 30% of the population is on Medicaid, and it pays for basically 50% of all births. It represents 10% of all Medicaid spending nationally. And I don't remember off the top of my head what New York's population is relative to, the national population, but New York's Medicaid program is disproportionately larger as a share of, Medicaid spending than it is as a share of the population in New York relative to the United States. That being said, I would not say, we're doing anything we shouldn't be doing. We're just using the rules that are available to us. And, we have people like myself and others who've come before me and, others on the health team in New York that are very skilled at coming up with ways to maximize Medicaid funding. And, it's water follows the path of least resistance. And, we look to figure out how can we best utilize and most efficiently use the state's taxpayer dollars for the best for the best of the residents in New York.
Thank you. That was very informative. The next question we have is, are there ways to combat the federal government when its actions are quote unquote unconstitutional or unlawful?
So we have a system of federalism in the United States where, when the federal government makes rules, that tends to preempt states. However, there are certain circumstances where states can have protections that go beyond what the federal government, requires. New York is fairly ubiquitous in, taking these kinds of actions where we, further protect, patient rights or individual rights, even through our state constitution. But in terms of combating things where it's unconstitutional, the state can and has taken steps to participate in individual and or multi-state litigation through, the Attorney General's office, where federal rules or laws are viewed as either unconstitutional or violating, one of the things that's common is violating Administrative Procedures Act, not, allowing sufficient participation or notice in a rulemaking process. And New York is actively involved in ongoing litigation on a number of federal rulemaking and or changes that have been introduced by the Trump administration.
Thank you. The next question has come in from Ray Koslowski, so I'm going to read it out. The budgetary reductions eliminating eligibility for certain non-citizens reminds us of the 1996 welfare reforms, in which most of the budgetary reductions came from eliminating eligibility of legal permanent residents for any monetary assistance. As a resident of New Jersey at the time, Professor Ray says that Governor Christine Todd Whitman providing grants to NGOs to help legally permanent residents naturalize was one of the steps taken. So the question is, could such kinds of New York State assistance to helping resettled refugees and others adjust status to legally permanent residents and assist LPRs, permanent residents, to naturalize, help reduce New York State Medicaid costs?
I just want to say I'm happy to. It's a long question, and I'm happy to clarify if need be.
Yeah. No, I got it. I think I got it.
All
So, so yes. So, you're exactly right to say that this brings back to the debate that happened subsequent to the 1996 Welfare Reform Act, the Personal Responsibility and Work Opportunity Reconciliation Act. And subsequent to that, New York State enacted Social Services Law 122, which eliminated eligibility for certain lawfully present or permanently residing non-citizens permanently residing under the color of law from Medicaid eligibility because the PRW OA, or whatever the acronym is, had made it optional for states to cover lawfully present non-citizens. New York, I think, and I'm actually working on this issue right now, but it appears to me that New York might be the only state in the nation that had litigation to this effect. It's called Alyssa v. Novello, and the heart of that case was, when New York enacted Social Services Law 122, we were relying on our emergency Medicaid program, which only covers critical life or organ threatening procedures. And at the time, it didn't even cover, asthmatic pharmaceuticals or dialysis, which are today covered. And several of the Alyssa plaintiffs required those types of services. And the court said, emergency Medicaid is insufficient to provide ongoing care for these individuals who are living with the knowledge and acquiescence of the government. And further, the state has a constitutional requirement to provide care for the needy and an equal protection clause. And the case was, litigated using a strict construction test rather than rational basis test. And as a result, New York covered persons, so people who were on a path to citizenship within the 5-year ban for Medicaid, or persons who were permanently residing under the color of law. Fast forward some time, there were additional, eligibility statuses that were created, temporary protected status and refugee, and New York included those in that coverage. When the ACA was created, those individuals who the state was paying for state only were made eligible for subsidies through the Affordable Care Act. And New York created what's called a basic health option, or known as the Essential Plan in New York, and was able to basically finance coverage for roughly 500,000 people with entirely federal dollars, because the way that funding mechanism works is it's a pass-through of 95% of what the federal government would have provided had that individual purchased coverage on the exchange through advanced premium tax credit payments and cost sharing reduction payments. So New York actually really benefited from this provision in the Affordable Care Act, making lawfully present non-citizens eligible for subsidies through the exchange or through this waiver program, the basic health plan. What the bill does is take away the state's ability to use those subsidies to finance the care, but not our obligation to cover them. And so, this is what is being viewed as, the most significant cost, because to cover these individuals in Medicaid, all 500,000 of them, then that's estimated to be about $3 billion. Now, the reason that there's more to think about there is because one of the things that came up in the case, and this is sort of a preview of what the work we're doing right now, but one of the main bases of the case was that persons who are residing under the color of law are not subject to deportation. However, the Trump administration has revoked the lawful permanent residence of a number of classes of immigration classes. So people who are in temporary protected status, for example, may now be subject to deportation. And it's also changed the definition of qualified immigrant under Medicaid. So someone who's a refugee, an asylee, or under parole is no longer eligible for federal financial participation, making those individuals potentially PRU-qual, we call it, persons residing under color of law. And so you have some shifting around of who is potentially now an ELISA class member, but then also, what's the most effective way to finance that coverage, and how, what it would seem that, there's only one or two decisions, but it turns out there's actually a whole buffet of options for the state that the state needs to be thinking about in terms of, what its obligations are and how far it wants to go in terms of coverage for lawfully present adults. And the one thing I'll just finally add, I know you want to jump in here, is in looking through this, there are only 3 states that seem to really cover lawfully present adults: California, Pennsylvania, and New York. The others, like New Jersey that you referenced, for example, either grandfathered their lawfully present adults as of 1996, like 4 or 5 of them did that. And then the remainder kind of offer, as you said, like subsidies to purchase coverage or access to a network of healthcare providers, if you will, but not full Medicaid. New York is really the sort of alone with California, maybe in Pennsylvania, in doing that. So could it reduce Medicaid costs? Potentially, but it has to be, because of this litigation, we don't have the flexibility that all of these other states do in dealing with this particular issue. And sorry if I gave you a dissertation on this rather than a short answer, but I'm spending a lot of time on it right now.
It was very helpful, actually, and I asked a long question. So, but I guess for me, it's thinking about moving forward and what interventions, because there are about 1.4 million legal permanent residents who have been in the United States long enough to naturalize, yet they have not opted to naturalize, to apply for naturalization. And one of the big barriers for a lot of them is, the $750 application fee. And it would seem to me that's a small cost to pay for an application fee if that's what's stopping them. And these are oftentimes older legal permanent residents who, if they were to naturalize, would be in a less precarious state with respect to access to federally government financed healthcare.
Yes. And it seems that that's the goal, right? Is to get people through going into the naturalization process. Yeah. As far as fees go, the bill also imposed significant fees in terms of, even obtaining temporary protected status or asylee, refugee status. And those are separate from new fees associated with obtaining work authorization, which also becomes relevant when the work requirements come into play. Mm-hmm. And so I think we're going to see some shifts around in, trends for these populations, because there previously were not substantial fees to obtain such statuses.
Thank you very much.
Thank you, Jillian, for all the information that you shared with us. We have reached the end of today's discussion. I want to thank our speakers. I want to thank both Ashley and Jillian for sharing their insights on this important topic. And I want to thank you all for attending. Today, as I shared earlier, was the finale of our Fall 2025 Lunch and Learn series. We're going to reprise the series in spring 2026, and I look forward to having you all with us again. Goodbye, and have a good rest of the semester. Thank you all.
Thank you so much.
Thank you, everyone.